Hello, and welcome everyone to a very special edition of the Lipid Insights podcast. I'm coming to you live from the NLA Fall 2025 Clinical Lipid Update in beautiful Scottsdale, Arizona. I'm your host, Dr. Peter Jones, and I couldn't be more excited about being here surrounded by a whole group of the brightest and most passionate professionals in our field. If you're tuning in from across the country, this podcast is your backstage pass to the ideas, conversations, and energy that make the CLU experience unforgettable. We've got a fantastic discussion ahead, so let me dive into the spirit of this NLA Fall CLU. Today, I'm here with Dr. Nihar Desai. He is an associate professor of medicine and associate chief of the section of cardiovascular medicine at Yale University School of Medicine and investigator in the Center for Outcomes Research and Evaluation and executive director for value innovation at Yale New Haven Health System Heart and Vascular Center. Now, of course, his CV is multiple pages long, so what I'm going to do is I'm just going to turn it over to Dr. Desai. What really drives you, and what do you do every day that gets you to work?
Well, first, let me just say what an honor to be with you. I couldn't more fully endorse what you said around the excitement and energy at the meeting here, the things that people are talking on, the things that they're working on. I think everyone leaves this meeting energized and invigorated, and it is a very beautiful setting. And so I'm absolutely delighted to be with you and obviously with our audience. I would say, Peter, you've given me maybe more accolades than I deserve. I think what I like to do every day is wake up and think about, what do patients need? What do the community that we are here to serve need? And sometimes I'm in the hospital. Sometimes I'm in the ambulatory environment with our fellows. Sometimes I'm in my office doing academic activities or maybe doing administrative and operational, activities. But I think the centerpiece of my thinking professionally is the patients and communities that we serve around cardiovascular disease prevention, guideline-directed medical therapy, trying to serve and to deliver for them what they and their families deserve and expect from the healthcare system.
Yeah, that is wonderful. You gave a great presentation yesterday in the opening session, which was about implementation strategies as it relates to the prevention in order to gain optimal cardiovascular health. And you were sort of giving us what the future is, guiding the future, how we reimagine our approach to achieving these preventative strategies. So, one of the things that was discussed in the whole session was about performance measures like LDL cholesterol. And, performance in achieving LDL goal is really in high-risk patients is low. And the question is why?
Yeah, Peter, I think you teed up the discussion and the question before us perfectly. I mean, I think we have to come to recognize the moment that we're in. Here we are. We have this very elegant and deep understanding of the pathobiology of coronary disease and cardiovascular disease at large. We have a set of clinical trials and guidelines that have continued to highlight the importance of LDL cholesterol. We have an expanding armamentarium of therapies to lower LDL cholesterol, the likes of which we've never had before in our professional careers. And yet, just like you said, somehow we find ourselves underperforming, too few patients achieving the goals that the guidelines would suggest that they should be at in terms of LDL. Despite all of these therapies and despite this understanding. And so one naturally has to ask the question of, well, how could this happen? And I think that really gets us to the next part of the discussion, which is there's a set of very complex and interrelated forces that I think are conspiring against the delivery system, against providers, against that patient-provider interaction. That really gives us what we have now, where maybe it's 20% of patients are actually achieving their LDL goals, 50% of patients are adherent to their statins, a year after an MI, and maybe 70% of patients don't even have an LDL tested following a hospitalization for an MI. And so I think that does represent the important work ahead. I'm certainly very passionate about this topic. I feel the stakes are very, very high because what we're talking about here is not about making a lab value look better or add or intensify a therapy. It's trying to prevent heart attacks and strokes and hospitalizations for our patients. These things are why we all went into this field and why we're so excited about this field. And so I do think the moment is ripe now for us to redouble our efforts, not only to understand the science and to appreciate and understand all the therapies that are available, but to commit ourselves to do that next bit of work as well, to make sure that that evidence and science makes its way to the patients and the bedside.
Yeah, I mean, during the discussion yesterday in the opening session, it was brought up about the three M's. We need to measure, we need to manage, and then we need to maintain. And that's all about LDL. Measure, manage, and maintain. And the question is, how do we get that performance value, and how do we get from a system that is payment based to some way we can come up with some delivery aspect to achieve that?
Yeah, I think you're exactly right. I think we have to be ready to reimagine the experience of patients. Right now, all of us have, and I will say my own system, is very much anchored to the traditional model of healthcare financing, fee for service, volume-based reimbursement. The more you do, the more patients you see, translates into clinical productivity and revenue generation. And I think increasingly, we all recognize, I think policymakers recognize, that for all the benefits of that model, there are some shortcomings and some blind spots. And increasingly, they're pushing us to a value-based model of healthcare financing where that revenue is tied not to the volume or intensity of service, but to the quality of care that's delivered, to the outcomes that are achieved for the patient, and to the efficiency of that care. And I will say, as a field and as a group of professionals that are gathered here across discipline, across specialty, but that are very much interested in preventing cardiovascular disease and preventing cardiometabolic disease, I think we should embrace that transition because it actually aligns perfectly with the work that we are all trying to do, where preventing events from happening, preventing hospitalizations, preventing the need for stents and bypass surgery is not only better for the patients, rewarding for their clinical teams, but then is also financially rewarded in that model. Wow, what an amazing concept that we actually can align the incentives in a way that traditional fee-for-service just doesn't do.
Yeah, and what I'm hoping is that you and others will focus and help come together to what we call implementation science, get this concept to those payers so that they understand that we're not paying you just to see a patient, we're paying you to prevent future events, which are going to cost us a lot of money. And how can we do that? And what do you guys recommend? And I'm hoping that you and your colleagues can actually help with a system that makes it easy for us overburdened clinicians to help our patients achieve this preventative cardiology perfection.
Yeah, no, that's right, Pete. And I think we've got to bring the joy of the clinical part of our lives back to our professional lives. I think so many of us went into this because we wanted to take care of people and we wanted to educate and engage them and empower them on their own health journey and their own healthcare journey. And I think increasingly we feel maybe more and more disillusioned, more and more disengaged in that. And I really hope that we can leverage this moment while people are talking about payment reform and people are talking about other policy levers, but that we don't lose sight of this is fundamentally about the work that's done every day in offices and hospitals and other care settings, and that we can never lose focus that that is the essential part of our work and our jobs.
It is, and what I'm hoping. I've really enjoyed this discussion. I hope our listeners have too, and gotten them a little fired up that maybe the future is going to be better and help change. But what I hope is that you and your colleagues, when we invite you to come back to future NLA meetings, will have a lot more to update us about how this implementation science is going to actually be done, and therefore make our lives and our patients' lives better.
Yeah, well, I'm 100% committed to continuing this dialogue. I think NLA has been such a powerful force for change and progress. And so to you and the other leaders of NLA, I think the whole field owes you a real debt of gratitude for the advocacy work that you are doing and continue to do, but also to create forums like this one where people can really come and have a real exchange of ideas, and for us to come together as professionals that are interested in prevention. And yes, I'm very much looking forward to continuing and to follow the work that's being done here, but also to give some updates and give some perspectives. I think the work that we are now focused on mostly is the implementation science efforts of how does one bridge the gap between evidence and practice.
Right.
We have been particularly interested, for example, in using the electronic health record to say, well, how do we leverage this very powerful tool that we have? It's ubiquitous in all of our healthcare interactions to make quality better, to make the interaction better between a patient and their clinician, to really bring quality and evidence to real-time decision-making. Others, I will say, other institutions are doing incredible work, leveraging care navigators or digital tools. I mean, we're at this point now, almost, it's a golden age in some ways. And yet we've got to be able to bring all of these pieces together to really test and study their implementation, what works and what doesn't, what can be scaled and at what cost. And then for all of us to have continued discussions about, hey, what makes sense for my group, for my institution, for my hospital, for my health system? And then how do we continue to build on that progress, again, for the benefit of patients?
That is wonderful. Listen, this has been a fantastic discussion. I'm excited about where this is headed, and someone like you leading this force. And we really look forward to having you come back to the NLA at some point with even more information and more positive updates to help us in this road we have in the long, I think, effort that we have to achieve optimal cardiovascular health in all of our patients. So
what an honor it was for me. Thank you for the opportunity, for the discussion, and I'm certainly looking forward to our paths crossing again very, very soon.
that's fantastic. Thank you so much. Appreciate it.
Thank you.